Good afternoon, everyone. Welcome to the first of 6 open forums on Telemedicine Now and How, made possible by a grant from the California Healthcare Foundation. Today's theme is effectiveness and connection via telemedicine, getting past the real and imagined hurdles. The forums are presented by the CSU Shiley Institute for Palliative Care in partnership with ResolutionCare, which has been pioneering telemedicine in Northern California. I'm Jennifer Ballentine, Executive Director of the Institute, and I'll be your moderator today. For those of you who aren't familiar with us, the CSU Institute for Palliative Care is a workforce initiative of the California State University system, offering online education in palliative care and care management for frontline clinicians and healthcare organizations. And now I'll introduce our facilitators. Dr. Michael Fratkin is a builder, innovator, and dreamer who approaches life and the practice of medicine with love and respect, incorporating principles of value-based payment, technology-enabled service delivery, and interprofessional team integration. Dr. Fratkin and his team have created ResolutionCare Network to build capacity for high-quality, home-based palliative care in rural Northern California and beyond. Dr. B, Brian Mistler, is Chief Operating Officer at ResolutionCare, a benefit corporation committed to deliver quality care to a racially, economically, and geographically diverse population that includes large rural areas in Northern California. Dr. Mistler is a healthcare leader with a deep understanding of the strategies that drive business impact and individual change. So without further ado, Dr. Fratkin and Dr. Mistler.
Just introduce yourself or add what you like, and then I'll take it from there.
Sure. Well, thank you. I just want to say thank you to Jennifer and to Maria and to others at the CSU Institute who have made it possible to be here today, and for everybody logging in. I'm excited about what we'll be able to talk about, and I know we won't be able to cover everything. So already be thinking about, if you have questions that don't get answered, to join us in a future one of these meetings or in the course that Jennifer spoke about. And please don't be shy. Ask whatever's on your mind. Michael, excited to be here with you.
Great. Thank you so much, Brian, Jennifer, Maria. Thank you, CHCF. Thank you all, y'all, to take a moment to take a little deep breath. It's been quite a sprint these last few weeks. I've got a couple of requests. It is extraordinary to have such a rich and full room of individuals, but I can't see your faces. So I'd like to ask you to step out of your comfort zone a little bit, turn on your video as able, take a look around, look who's in the room with you. It'd be really great for me to see you. And I know that you're less likely to wander off to the refrigerator or your Facebook profile if I can see your face. It's one of the realities of being in a synchronous interaction with other people, is that they see you, you see them. It's kind of beautiful that way. And part of what I hope to accomplish with this series of encounters is to just invite you to experience the personal and connected nature of this care. It's not what you thought it was, and it's not the same as seeing people in 3 dimensions in real life. It's its own new dimension of interaction. Marshall McLuhan back in the day wrote that the medium itself is the message. He was talking about television in the late 1960s and 70s, that the device itself is a part of the encounter. And in this sort of ridiculously fast implementation of real-time, synchronous video conferencing technology, we're exploring kind of new territory together, right? I'll give you a little background on what we do at ResolutionCare. We have been using technologies, video conferencing technologies, for about 5 years, since we launched a home-based palliative care program. And the thing that we've learned along the way are fully generalizable to each and every one of your specialties. How many of you are palliative care? Can you just raise your hand if you're a palliative care provider or part of a palliative care program? Looking around, glancing around, hold them up, hold them up, hold them up. Good, good, good. And then there's all those people on the third and fourth page who just won't turn on their video cameras. That's all right. We won't shame them for it. We'll just call them out. And now, if other specialties that you represent, raise your hand. Primary care specialties, nod your head if I'm guessing right. Right. So, I mean, it's a split. It's hard to kind of assess, but it's a split. ResolutionCare was launched a crowdfunding campaign back at the beginning of 2015. Realized that in the large geographic areas that we were working, that we could provide care to people using available gizmos and connectivity. And because of my specialty as a palliative care doctor, I focused my attention on the very sick folks. And because of the nature of palliative care being very person-centered versus disease-centered, it just makes sense that these technologies might help. So I tested it, and in about 2 minutes of my encounter greeting a woman with cancer in the Bronx, I discovered that the technology can actually disappear pretty easily. And from there, we have taken care of maybe 1,400 people and their families over a period of 6 to 9 months of time, using a combination of in-home care and video conferencing based care. Now that was true up until about 2 weeks ago. 2 Mondays ago, we were using about 45% of all the care that we're providing to our 180 people under care. About 40% of it was through video conferencing in all of the specialties of our team, which include nursing and social work and chaplaincy and physicians. By Wednesday of that week, 100%. And all of the concerns and worries have essentially been managed pretty effectively within those 48 hours, and with a few straggling issues and problems and obstacles to overcome. We're taking beautiful care of people as the persons that they are, not as the patients that they're identified with by many of the sites of care and healthcare. And it really does work. So until a few weeks ago, people would roll their eyes when I said telemedicine is better than real life. People aren't rolling their eyes so much these last few weeks. That's as much of an introduction as I want to give. I can just chatter on for the entire time, but this is actually designed to be a forum. This is designed to respond to questions that y'all have placed. And I'll be moving from screen to screen, just looking around. And when we get to your question, I'll try and find you so that you can interact directly. I also might suggest to folks that since it's so distracting to see everybody who's in the room, in contrast to what Jennifer said, you might enjoy just putting on speaker view so that the individual that's speaking is full screen for you. And as long as people keep themselves muted, they won't be falsely identified as the speaker.
So, thank you. We had about maybe 15 or 16 questions submitted ahead of time. Thank you very much for those of you who did that. They tended to fall into two categories, kind of around the personal interaction and some of the process pieces. So I thought we'd start with that personal interaction, and I kind of grouped several questions together because they're very similar in theme. And they really have to do with establishing trust and rapport. How do you do that through this screen, through a phone? What is the best way to show care and listening when you can't lean in or touch someone's hand or be in the same room with them? And I thought this was a very interesting question too. How do you use therapeutic silence on a call without having a patient or family feel like the call was dropped? So those are several questions kind of grouped together, but maybe some things that you can address.
The first thing to accept about telemedicine visits is that that they're different. We acknowledge that. I think oftentimes our mind thinks about all the things that we lose, the ability to touch hands and embrace and read an entire body language, but they're not as different as you think. And most of the skills that you've developed as clinicians translate very readily into telepresence. You see sometimes articles or news stories about hospitals that have tried to attach iPods or iPads to robots and put little eyes and faces on them, and they're in the emergency room or they're in a patient's room who's dying, and the family reacts negatively because there's this depersonalization. When you're using a platform like this, the exact opposite happens. If you don't, instead of trying to draw attention to the telemedicine, you frame it and then you let it disappear. And so my first piece of advice is to let the technology disappear. Don't look at the technology, don't draw your patient's attention to the technology, but look through the technology, see each other. If you have any kind of audio-visual problems, there's connectivity, address those right up front. Start your call by getting those out of the way, because if you're having trouble hearing each other, you're going to come back to that over and over again. And in the very moment when somebody's sharing the most important decision in their life, you're going to have to ask them to repeat it. And so you want to deal with the technology up front and then let it disappear into the background. The next thing to do is to bring all of your existing clinical skills to translate over video. You get a lot more information than you think. If you're used to having phone calls, you have one hand tied behind your back, you're at a huge disadvantage. But when you have a full screen chat with somebody and you can see their body language, you can get most of what you get in person, and you start to get a lot more because what you realize is that that person off screen who's maybe whispering in their ear when you're on a phone call and asking questions, you can't, if you're talking to them on the phone, you can't invite that person as easily in, but on video, you can invite them into the window with you. And so you have a wide angle lens into their life in a way that's not intrusive because they're setting the frame and inviting you in. The second part of the question about silence, I think that you can name it up front. You can tell the person, there's going to be moments when we don't feel like we have to fill the airwave. I think more quickly than you realize also, you see that if you're an active listener, that your silence, even just your minor movements on video, is enough to let the person know that you're present, that you're listening, versus the kind of frozen thing that you get when the video is cut out. So I think we come sometimes to video thinking about, our mind wants to think about all the things that are different, but if you start with the advantages and everything that translates, it really comes across. And the more positive experiences you have, the easier it gets. I saw Juan ask a question. I'm going to, Juan, see if I can unmute you and invite you to ask your question. You'll have to hit accept on the unmute invitation. Perfect. And then ask your question, and we'll try to address that next.
Thank you. Hello, everyone. The question was about privacy and with issues of privacy with Zoom. It sounds in one of the articles that I read yesterday that the New York schools have banned the use of Zoom, and that there have been people whose conference have been hacked. And I wonder if there are any issues with HIPAA and in healthcare.
Great. I'm going to look around for a moment and see if Dr. Fratkin's back online. Michael, if you come back in, jump in. I think we're seeing a couple of things happen. We're seeing, I think, some companies get afraid because Zoom is taking so much in the marketplace and elevating some of those concerns, probably, I think, beyond the nature that we really need to be worried about them. We also see Zoom addressing that really quickly. I don't have any stake in Zoom, so do your own research and make decisions. But what we're seeing in parallel is a number of waivers from the government that means that HIPAA compliance with video chat is not as critical as it was 2 weeks ago. That they've said for many of the things we're doing, you can use Zoom, you can use FaceTime, you can use Skype, you can use Facebook chat, you can use any of the tools available to you to make sure that you're serving patients as quickly as you can in their home. I think those waivers are going to stay in place long enough for any of the concerns about any of the specific platforms to be addressed. So I would urge you not to let that inhibit you from interacting with folks.
Great, thanks very much. I thought we'd look at another couple of the questions that have been submitted ahead of time. I think this is kind of top of mind for a number of people. Do you think telemedicine will become normalized and mainstreamed and stay in the regular practice that we're all having to pursue, or will it only be used for exceptional crisis or infectious situations?
I think that this was the future. This is the trajectory that we have been on for years towards more telemedicine, because it makes sense for so many reasons. It makes sense because if you have at a basic resource allocation level, you have 3 hours and you spend an hour in a car, an hour with a patient, an hour in the car getting home, or if you're in a clinic and the patient's doing the same thing getting to you, in those same 3 hours by telemedicine can help 3 times as many people. It's also true that in the history of the Western world, nobody has ever contracted any communicable disease by video chat. And so we see it, of course, especially important in these times. But I don't think we can go back. I think, of course, there are situations where people need in-home care. But I think that that proportion, I saw a meme the other day that said essentially, we're about to find out which meetings really could have been an email. We found out which in-person meetings really could have been video meetings. And as individuals realize what they can do to serve people in their homes more conveniently, what they can do to work more conveniently from places where they live, and how much more efficiency and capacity that creates in the system, I think there's going to be so much vested interest that it's going to be hard to go back permanently. There are still some areas where people need in-home care or in-clinic care, but that proportion has changed radically and our slope has just taken off.
Another question that came up is the question of an interdisciplinary team. So particularly in palliative care and hospice care, you want to have a number of clinicians involved, obviously, in the patient's care, and maybe the interactions are one-to-one. And what is the experience of telemedicine encounters with social workers, with chaplains, and how do you involve the full team in that?
So I should say, for the past 10 years or so, I've worked as a health administrator, managing medical centers and university campuses and palliative care. But before that, I was a psychologist for a number of years. And Michael always tells me I should start with introducing myself as a psychologist because people don't really like health administrators. So I'm trying to do that more. But I think that I have, because of that background, look at our interdisciplinary team from multiple levels, thinking about it at a systems level and thinking about it at the level of a clinician or a mental health specialist. Resource-wise, if you talk to the CFO of your agency, they would tell you that some people's time costs more than other people's time to provide. And so what the implications of that are also that people have different expertise. And so what an interdisciplinary team allows you to do is, one, make sure that you're using people to the maximum of their expertise, and that you're combining the expertise from different systems or from different professions. Not everybody has to have direct patient contact in order for that to happen effectively. And so the way we work at Resolution Care is we have an interdisciplinary team that consists of social workers, chaplains, physicians or other advanced care providers, and care coordinators, community health workers, all of these things working together. It may be that a nurse meets with a patient for half an hour, but outside of that meeting, he or she brings back the context, the information, shares it with other folks on the interdisciplinary team, gets advice from the social worker, are you thinking about this resource, gets advice from the psychologist, are you thinking about their barriers to health in this way, and brings it back to them. So my model of interdisciplinary team doesn't have to mean 10 different people meeting with a patient. In fact, if you've used any service, there's more and more movement towards having that. It's easier whenever you call a company and you get a different person every time, it feels disconcerting. So there's something nice about having one or two people hold that relationship and then be access into a broader system behind that can provide all those different languages of care. The last thing I'll say about interdisciplinary teams is that they serve the patient, but they also serve our interaction with the system. And our social workers, as a psychologist, our physicians, our nurses, they all have different ways of thinking about and interacting with our community resources, our hospital partners. And so having those resources on our team to make connections to their colleagues and equivalents at other institutions also means that you get information transfer between systems more efficiently. So if you're not thinking about interdisciplinary teams, I encourage that. And telemedicine opens that up in a way that just wasn't possible before, especially if you're in a rural context or you're in an otherwise under-resourced area. You might not have access to a psychiatrist or a full-time social worker or you may be an agency that's not big enough to use those resources locally. With telemedicine, you can bring those people. You can have a social worker living in Los Angeles and a chaplain living in San Francisco and palliative care in Northern California, and you can bring them all together. And we do exactly that. There's not a single one of those disciplines that we found can't be provided by telehealth. All the barriers that you can think about across the entire lifespan, including the complex issues around death and dying, our chaplains, our nurses, our physicians are all providing care in exactly this medium.
Thank you so much for that. Just want to remind everybody that you can enter your questions into the chat box or raise your hand if you have a question. Another question we had was having to do with platforms. So I think there's a concern, whether it's valid or not, I don't know, that older patients might have a real struggle with the technology. Certainly patients who are cognitively impaired, perhaps, or don't speak English as a first language. What kind of platforms do you recommend, and are there any adaptations or accommodations that you find are helpful?
So, I think that so many of the platforms have, Michael, perfect. Welcome back. We're just answering a question about platforms, and then we'll bring you back in. The question is, are there any platforms that are better than other, and how to help, especially older adults or folks who may have challenges accessing them? What we find, I think, is that the best platform is the one that you have access to quickly and is as easy to use as possible. We're all using Zoom today. We use that with a lot of our patients and don't have any problems, but there are a number of other platforms out there that provide essentially the same service. And of course, some people have a challenge navigating them in the beginning. And oftentimes there are resources in their life, a child, a grandchild, a friend, a neighbor who can help help them with that. It's also sometimes possible very easily over the phone to get somebody onto the Zoom platform just by walking them through those steps. And the last thing that I would say is that you're not only helping somebody develop a tool so that they can access your services, but you're giving them, especially we see this now with COVID, you're giving them a tool that they can use for the rest, for the wider angle of the rest of their life. Once you show them how to use, especially a free service, if you're showing them how to use a proprietary service, some degree that translates. But if you're showing somebody how to use Zoom or Skype or something like that, they can go away and use that same service to have an Easter party with their family or a Passover celebration with their grandkids, and all these tools that bring connection into their life and help alleviate loneliness in a way that you can never have an impact on in 1 hour or 2 hours a week. But if you're adding that resource and spectrum to their life for the other time that you're not together, you've done them an incredible service.
Yeah, I'd like to also just add that the work that we do in walking people through the steps, our care coordinators, our operational staff are really skilled and capable at connecting to people, whether it's by telephone for confirming about an appointment, or whether it's walking them through the steps that it takes to do something that people have the pre-existing bias will be difficult. It's not actually difficult. And every encounter that we have with somebody under our care is an opportunity for relationship building, trust building, a little bit of humor. For example, my departure over the last 20 minutes and my reliance on Brian is one of the realities, is that these things are not perfect, and that my internet connection went down for 10 minutes while I was supposed to be meeting with y'all. So having a pretty light heart about all of that and just returning to it, not giving too much energy to the technology piece, allows you to then kind of enter a window of communication and relationship with people.
So on that note, Michael, I thought I would circle back to a question that Brian answered very nicely, but I thought it would be interesting to get your perspective. And that has to do with establishing trust and rapport, and the best way to show caring and listening when you can't lean in, and particularly on the phone when someone can't see you. How do you do that with technology?
I think in the way that I just did it. What you might have noticed is that I really called out what was true. It's like, I called you all together. There's 101 of you here to talk with me today, and I just disappeared. So I spoke to that directly. I gave a little bit of lighthearted, you can relate to that situation. I managed the break in the communication, and then I started again, right? So now I'll start again. Now we're going to begin to answer that question, which is the relationship that you build is entirely a reflection of your ability to use the frame, disappear the technology, and enter into engagement. It's your ability to be present is what will depend on which will be the greatest factor in connecting with people. There are some tricks. One thing you've noticed, I've got a kind of well put together little home office with this bit of clouds and my little painting over there. I'm comfortable in my own space. I have good lighting. I'm not behind me, there's no bright light source. I can see that Douglas Brown has chosen to use the celestial background. There's a virtual background function in Zoom that's both fun and also either distracting, or actually it removes the contextual framework of where you are calling from. You can experiment with that. But the things that you can do to just essentially bring yourself into a framed encounter with somebody and connect with them directly without the technology in the space is exactly the kind of thing that you do when you've learned how to walk into an exam room, or when you've walked to the bedside. You have a certain, maybe even unconscious understanding of the things that work for you. When you walk into that space, you have your own scripting, and maybe you do you're maybe aware of the proxemics, or where you stand in the space, or how, what level of view you give to the person that you're seeing. Many of us in palliative care, we make it a habit to sit down, to take the time to set the space. And then once you set the space, then you begin to do the encounter that you would otherwise do.
Thank you.
Did that cover it, do you think? Yeah.
Sorry.
Yeah, did that seem to respond? Yeah.
Yeah, great. Kind of alternating between patient experience and process questions here. So one very interesting and possibly challenging question is, how effective is telehealth? And I assume that means, as compared to an in-person encounter, or, what's been your experience in terms of the actual effectiveness of the medium?
I'm not just being cute when I say that it's better than real life. It's substantially better than real life. For our practice in palliative care, we're inviting people to engage with us, our team, to improve their quality of life. And in the traditional structure, what we ask them to do is ask their, usually daughter, to take a half a day off from work. We ask them to take their seriously ill self and shower and prep and pick out their clothes and get dressed. For some people, that's nothing. For some people, that's like a big lift. And then we're asking them to get their walker, their wheelchair, and with the help of their daughter, into the car. And depending on where you live, maybe they're fighting traffic, maybe they're fighting parking, and then reversing that to get inside the building. Then they walk into the building, they walk into a waiting room where there's people coughing and sneezing. Even before COVID, that wasn't very relaxing. And then they get that clipboard, that clipboard that they always give you. They've had 5 visits in a month for labs, for appointments, for infusion, for whatever it is. And they have to deal with that damn clipboard again and again. They sit down and they look at the people in the waiting room and wonder, is that person sicker than me? Am I sicker than them? I saw them last week. They don't look so good this week. How do I look? All of those experiential concerns and anxieties are in the space. By the time 30 minutes late, they drag that person into an exam room, sit them down in a windowless room with or without their significant caregiver person. And then the doctor comes in. And the doctor does this. Nice to see you today. What can I do for you? Please answer these questions while I'm typing my point of care documentation into the space. While you can tell that that provider is very concerned about the clock. And then maybe, just maybe, by the time they get up to leave and put their hand on the doorknob, you remember that one thing that you really needed to get answered. And maybe they pause and sit back down, or maybe they don't. And then the whole thing goes in reverse. That's all the practical stuff that's in the way of an exam. They've also walked in and been identified. When they walk through that door, they become the distinction patient, right? And you, with your white coat and your stethoscope or whatever it is that you wear, or encumber yourself with, become the distinction provider, doctor, nurse, social worker, whatever it is. You become identified with your role rather than yourself. So there's all that goes away. And when I encounter people in their home, I'm also not invading their home. I love doing home visits because I love doing home visits. I love to knock on the door, be taken inside, hosted, sometimes offered cookies, sometimes get attacked by crazy dogs, and see all the sort of nuance that you can see as soon as you walk into the room. There's so much intimate detail and information that you get as soon as you walk into the room. And while they've invited you, they haven't consented for you to smell how difficult it has been for them to maintain the hygiene of their home, or the hygiene of themselves, or the hygiene of their dog. They've invited you into your home because you told them you had something of value on your terms. It's kind of a home invasion, even though it's quite enjoyable and exciting. When you do it this way, they click on a link, you click on a link. I'm sitting in the environment that I prepared. They're sitting in their home. They're not identified as a patient in their own home. They're a person sitting on the couch, their cup of tea, their cat on their lap. If I'm 5 minutes late, big deal, right? There they are at home anyways, right? Now, it's funny how much more on time we tend to be when we've got scheduled video conferencing versus when we've kind of become accustomed to being all, fudging our schedule and being late and throwing things in the clinical environment. But using this kind of scheduled encounter through video conferencing somehow magically, we tend to be like, we really want to be there at 10 o'clock, if that's when we said we were going to be. So we're more on time. And then there they are sitting in their own environment and in their own life, and you're in your own comfort space, and everything that they show you, you have to ask their permission for. You ask them, who's that person on that picture behind your head? What's your dog's name? Is there anybody else in the room? How do you manage your medicines? Where do you keep them? Would you mind showing them to me? You've talked about your garden. Are you up for showing me your garden? these kinds of things are all consensual engagements that personalize it. I have a thing where I like to look in people's refrigerators. Seems like I learn a lot by looking in their refrigerators. But I have to ask them to do that. I don't just barrel into their household and start looking around. It turns out, from a pragmatic point of view, when you engage people in their homes, something sort of surprising that I don't quite understand happens. A palliative care consult has a certain arc to it. There are elements that I consider to be necessary to complete the encounter. I would schedule 90 minutes. I know that for those that aren't palliative care providers, that seems like, wow, what a luxury. But that's what I used to do. When I started doing video conferencing based consultations, I discovered that all of the elements of my initial consultation could be completed in about half the time. We can talk about that if you're interested, but it's quite interesting how efficiencies sort of emerge from a much more framed encounter. And then the last thing I'll say is that there's something in the field of palliative medicine and pretty much in any other specialty, the exquisite importance of having solid boundaries couldn't be more important in palliative care. And the frame itself, and the fact that they're in their comfortable environment while I'm in my own, provides me not detachment, but actually the ability for greater intimacy, because that boundary is protected. Again, for those of you that think a little bit about the sort of social psychology or experiential dynamics of how we engage in service or how we engage in healing practices, we can talk for hours about that. But I just wanted to at least plant that seed. I'll be talking more about that kind of thing in the masterclass that we've got scheduled.
You touched on this in what you were just saying, but we had a question come in through the chat from Seiko Izumi. Any comment on how to handle persons on the screen other than the patient? So as you mentioned, the other person in the room, the kid walking through, neighbor stopping by, specifically in terms of confidentiality. How do you handle that?
Yeah, well, I handle it generally with a sense of humor and a direct encounter. Like this particular being is, it kind of barks sometimes. I acknowledge the people in the room. I invite them into the space. I check in to make sure if the individual that I'm speaking with needs more privacy in order to be clear, and are they consenting, or did that person just happen to just be hanging out in a lazy boy during the encounter? I make sure that everything in the environment is in my awareness, like people off camera. I want to know, is there anybody else in the room? And then if they're in the room, are you comfortable speaking, or would you prefer it if they stepped out and we had privacy? We just name all of the elements in the environment, and all of a sudden we find ourselves much more conscious of all of the elements that determine the nature of the encounter. So I just name it, talk about it, normalize it, provide control to the individual who's trusting me with their care to be in charge of the experience. And then once I've got that all set up and handled, then I very explicitly say, okay, so we've got it all set up. Now let's begin. And then I do what I do, what you do, what we all do.
My question is, how are physical assessment requiring palpation, consultation, et cetera, managed and later documented to ensure that the chart is complete?
Perfect question. As you can imagine, it's observational, right? You don't get to poke and prod. You don't get to palpate and percuss, but you do get to ask again, consent to see or observe. We have a number of our patients, or most of our patients actually have, blood pressure monitors, pulse oximeters when that's relevant, weights. And we as a palliative care organization are not responsible for the kind of high exposure physical exam screenings that a primary care practitioner is. We know exactly where our lane is in palliative care. So we have collaborative, coordinated relationships with all other members of the care structure around a person. So we have access to home health, we have access to cardiology, we have access to the oncology group and the primary care practice. What we're able to do is quite a lot more than you might expect. I've listed it out with my physician colleagues. There's about 40 elements of a physical exam that we can very reliably and comfortably document. And then at the end of that documentation, I then say the remainder of the physical exam is deferred due to video conferencing context. But I put as much in there as is accurately observable. And it's plenty of stuff. Now, in other specialties, if you're a primary care provider having to evaluate acute and episodic illness, there's a place where you have to know you're getting to. You don't have to pretend you can see more or evaluate more or gather more data than you can. You just have to know where the limits of your data collection are, and then engage with other sites of care, other approaches to evaluation when it's necessary. Does that answer that question pretty well? Am I seeing some nods out there? Gina's giving me the thumbs up. Good, good.
So a couple of questions, very similar, having to do with patients with dementia and how, you know, that telehealth visit with someone who has dementia might be a particularly difficult. And so families report that they're looking kind of blankly at the iPad, whereas in person, there's more opportunity to really make that connection. So tips, tricks, suggestions?
I think, again, is as you become a student of the medium, probe, ask questions, engage, seduce, make sure you've got the attention of individuals, bring them forward, test them, probe them, ask them silly questions, engage them in things that are a little less obnoxious than do you know how to spell the word world backwards, but engage them to demonstrate their capacity to be involved. Now, it is absolutely true you can't do everything with telemedicine. I used to say about 4 weeks ago, I used to say it'll be probably 5 to 10 years before about half of all substantial provider encounters are provided by video conferencing and telehealth technologies, with the addition of remote patient monitoring stuff, which we can get into later if people are interested. I used to say it would be 5 to 10 years before that would exist, but I was wrong. It turned out it was more like 5 to 10 days. And in fact, it appears that maybe 70% of healthcare encounters are being done this way in like a week, right? Not all, but many of the regulatory barriers came down, and the circumstances where we are dedicated to the safety of the people we care for and the safety of our team and the safety of ourselves as healthcare provider changed the world on a dime in a way that, I don't know what the sweet spot will be, but there's been a number of metaphors about whether or not the regulatory changes will persist. But the metaphors include things like you can't put toothpaste back into the tube, the horse is out of the barn, the genie's out of the bottle. You can put in the chat box some other really groovy metaphors to mix up. But the truth is that this is a change, a transformation in healthcare delivery that is going to persist. That you all are recognizing, you want to engage with really thinking about this very new medium, suggests to me that you all will be the champions of this work going forward.
So here's a question that is more sort of urgent. Someone is saying, I believe I will be part of the team who is talking to family members who are at home with a COVID-19 patient in a hospital with no visitors. So the patient's in the hospital, the family's at home. It will be a crisis situation with us having conversations about care. We won't have met the patient. this is the first time encountering the family. Any pointers on that kind of a crisis situation, immediate decision kind of conversation?
Have any of you had limited access to family members for these important kinds of critical decisions historically, long before COVID, right? Are we nodding? Am I seeing some nods? Where we've been limited every day. We've been limited in our ability to engage people with their diffusely distributed families for the longest possible time. In fact, when you look at who's got advanced care plans that are well vetted by family, it's a small percentage of people, even with the most serious illnesses. This is an opportunity using these technologies to actually do what we weren't able to do previously. So I tell a story about a man that I took care of in the hospital about a year and a half ago, who was a Native American man. His mom was a Native American elder, kind of a special woman by the name of Aggie Pilgrim. She was the chair for 10 years. She was the chair of the International Council of 13 Indigenous Grandmothers. It's a wonderful and locally famous woman. Angie Saunders, you shake your head. You look like you might have some Native in you or something, but you know Aggie. And her son was dying. By the way, I have Aggie's permission to use her name in case anybody's wondering. Her son had a hospitalization in the intensive care unit with a terrible pneumonia in the context of some lung disease, and he had sepsis, and 7-8 days into it, the decision was made to take him off the ventilator and see if he could do what he needed to do on his own. And the family was wondering whether it would make sense to consider putting him back in the ICU if he was to decompensate. And so I walked into the room, and there were like 15 people in the room, multiple generations. And at the end of the bed on a rolling table was a computer with another 15 family members from Maryland and Florida and wherever they were from, with kids on their laps and mute buttons, thank goodness. But I had nothing to do with setting that up. This family put it together. These technologies are here and they're coming, right? And we were able to have this comprehensive family meeting that involved all the stakeholders. I introduced myself to each of them. I asked them to tell me their name and who they were in relationship to the fellow that we were talking about, who was not quite able to participate. And so we had, for me as a palliative care doctor, the more the merrier. The more people in the room to have this conversation with, the less likely it is that as soon as I get finished, somebody's going to come out and bring some chaos or a new idea or a new point of view that wasn't addressed. Getting everybody on the same page and choreographing a consensus-based approach as a family is one of the great joys of my life. So we weren't able to do family conferences in any reasonable way. There was always the daughter from Des Moines, or the cousin, or the brother who was an anesthesiologist from New York City. Oh my God, those anesthesiologists from New York City, So this allows me to get everybody in the room, everybody relevant into the conversation at the right time, and everybody on the same page, inviting them to come forward in a way that I never had before. So specifically to the experience of doing it, everything that I've already talked about, getting the technology right, bringing everybody to a state of relaxation, having everybody actually put down the device. Like if people hold it in the hand and it jerks around, it doesn't disappear. When they prop it up on the table next to whatever, so they've got their hands free, then it's just a window in which they're interacting with the people that they're participating with. But all of those principles, getting all the technology right, everybody's anxieties about it out of the way, and then beginning the conversation. We are here today to talk about some very, very difficult and important things. I want to thank you all for arriving. Are you comfortable to begin the conversation? And then you begin the conversation. You do the thing that you've been trained to do. Or if you need training, email me and we'll get you all comfortable with some of the tricky communications. There are some very useful, very COVID-specific communication tools that have been made available to any and all of us by the Center to Advance Palliative Care. For those that recognize, Vital Talk has been an important communication expertise platform in our field that has created some really great tools using their army of thoughtful palliative care communicators to help guide and answer the frequently addressed questions that come up for family members. What we don't want is we don't want people to get the care that doesn't reflect their preferences, right? And we don't know what their preferences are unless we ask. And so there are some very thoughtful prompts and the materials that I'll ask Jennifer if you could put the CAPC COVID toolkit on a follow-up communication to the registrants. That would be really useful. There's a little blog piece where I talk about the kind of experiential stuff in a little bit more detail too. There's tools related to regulatory and policy changes that are dynamic and being updated on a regular basis, state by state, issue by issue.
So what about considerations or tips for virtual visits into acute care settings? So you have the patient is in the hospital, and how might you conduct that kind of an encounter?
Yeah, it's tricky. You may need a partner, right? If you don't really want to be trying to train people to use their devices if they're real bad sick, right? However, some people in the hospital are capable of managing the gizmo on their bedside table. Sometimes you may need to get help. The folks in the front line in the hospital are super sensitive to the isolation experienced by acutely ill people that are hospitalized right now. It may take a little bit of creativity to find out who is your proper partner, but it may be very useful to have somebody facilitate the video conference by managing the device themselves. Beyond that, it's the same principles, right? Hands-free, reasonable lighting, acknowledging the environment and setting of the setting for the encounter, and then beginning by explicitly stating, now we are beginning the encounter. So truly, it's not very much different in terms of the principles. I think that what I'd like to leave you with is using telemedicine to provide care to people who are ill is a lot harder before you've done it than it is after you've had a few experiences. It took a while for you to learn how to use one of these gizmos to communicate with people, and it'll take a little while. Although I think it's easier to use the video conferencing platform than it is to actually speak on the phone and effectively communicate with people, because it's so much like what we're used to. So yeah, I just want to challenge and interest you all in being curious and exploring this completely new frontier of healing and engagement.
Thank you so much, Michael and Brian, for this time, and just encouraging everyone to join us again next week, and/or invite your friends for next week. I want to thank again the California Healthcare Foundation, as well my amazing team who pulled this together in a very short period of time, and we will see you all next week.